Hey everyone, welcome to the human side of hospitals. I'm so glad you are here. And now on this channel, we don't just talk about medicine, we listen to real people, to patients, to doctors, nurses, caregivers, anyone who has an unforgettable hospital experience. The hospitals can be places of healing, hope, sometimes even heartbreak, and every story has something to teach us. That is why I'm starting this, just to give people a space to share, to be heard, and to remind us that behind every hospital wall are human beings with stories worth telling. Now, here's where you come in. So, if you've ever been a patient, if you've worked in a hospital, or if you've supported a loved one through their hospital journey, I would love to hear from you. And you can send me a short video, audio, just write your story down. Or if you would like to sit and chat with me, you can join me live on Zoom. And all you have to do is just fill the form in the description below, or you can send me an email. And it doesn't matter where you are from, who you are, or whatsoever. You are welcome wherever part of the world you come from. And before we dive in, don't forget to hit the subscribe button and turn the notification bell. Basically, not to miss these incredible voices from around the world. And a quick disclaimer before we start: these stories, their personal stories, shared with full consent, and we are here just to inspire, educate, and raise awareness. One thing is those who want to remain anonymous online, well, for the sake of confidentiality and privacy, altered some of their voices into AI voices. And note that even the advice shared in these videos or in these experiences, they are not a substitute for medical advice. Always remember this. And if you have health concerns, always speak to a qualified healthcare professional. All right, let's dive into today's story.
I'm Dr. Vincent Castellanos, Chief of Cardiothoracic Surgery at St. Helena Medical Center in Tampa, Florida. Or at least I was until I tendered my resignation 3 weeks ago after 22 years of dedicated service. I graduated summa cum laude from Johns Hopkins School of Medicine, completed my residency at Mass General, and earned my fellowship in cardiac surgery at Cleveland Clinic. Over the past 2 decades, I've performed over 4,000 cardiac procedures, from routine bypasses to complex valve replacements and heart transplants. St. Helena Medical Center is a level 1 trauma facility with a state-of-the-art cardiac wing that I help design. The operating suites are equipped with the latest advanced surgery, advanced imaging technology, and monitoring equipment to track every heartbeat, every breath, every drop of blood pressure with millisecond precision. I've worked alongside some of the finest surgeons in the country. I've trained dozens of residents who have successful careers of their own. I've seen everything you can imagine in cardiac surgery. I've operated on infants born with congenital heart defects so complex they defy textbook descriptions. I've performed emergency procedures on trauma victims whose hearts were shredded by gunshot wounds. I've transplanted hearts from donors whose families made the ultimate sacrifice.
That's okay.
And I've held beating hearts in my hands more times than I can count. But what I'm about to tell you is the one case that shattered everything I thought I understood about neurophysiology. Forced me to abandon the profession morning of October 15, 2024 started like any other Tuesday in the cardiac ward. I arrived at St. Helena at 5:30 a.m. for my usual pre-surgical review. The first case on my schedule was what appeared to be a routine mitral valve repair on a 43-year-old construction worker named James Kowalski. His file indicated he'd been experiencing shortness of breath and chest pain for several months. The echocardiogram showed moderate mitral regurgitation, a relatively straightforward repair that I'd performed hundreds of times before. Kowalski had been admitted the previous evening for pre-surgical preparation. His blood work was unremarkable. His EKG showed a normal sinus rhythm. His chest X-ray revealed unexpected signs of cardiac enlargement, consistent with valve disease. Dr. Sarah Mitchell, my chief physician, had performed the initial evaluation and confirmed everything was proceeding according to standard protocol. At 7:15 a.m., I met with the surgical team in operating room 7. My team consisted of Dr. Mitchell, anesthesiologist Dr. Ramon Gutierrez, perfusionist Linda Wong, and scrub nurses Angela Davis and Michael Torres. We'd worked together countless times, and I trusted each of them implicitly. Dr. Gutierrez began the anesthesia protocol while I reviewed Kowalski's imaging studies one final time on the large monitors surrounding the surgical field. The patient was wheeled in at 7:45 a.m. and we began the standard preparation. Dr. Gutierrez administered the propofol effectively, and within minutes, Kowalski was under general anesthesia. The monitors showed stable vital signs. Heart rate 68 beats per minute, blood pressure 110/70, oxygen saturation 98%. Everything appeared completely normal. I made the initial incision through the sternum at 8:12 a.m. using the standard median sternotomy approach. The bone saw cut cleanly through the sternum, and I used the retractor to open the chest cavity. What I saw when I looked inside should have been routine. Pericardium covering the heart, great vessels, the lungs on either side. But something was immediately wrong. The heart was beating, but it wasn't beating in the right place. Instead of sitting in its normal position, slightly left of center, Kowalski's heart was positioned completely on the right side of his chest. This condition, called dextrocardia, occurs in roughly 1 in 12,000 people and is usually detected in childhood. But Kowalski's chest X-ray from the previous day clearly showed a normal heart position. I had reviewed it myself multiple times. Dr. Gutierrez, I called out, "Can you pull up yesterday's chest films on monitor 3? The X-ray appeared on the screen, and I stared at it in confusion. The heart was clearly visible in normal anatomical position on the left side of the chest, but the heart I was looking at in the open chest cavity was definitively on the right side. Dr. Mitchell, I said, when was this X-ray taken? Yesterday at 2:30 p.m. during admission workup, she replied, checking the timestamp on the image. I looked back into the chest cavity. The heart was still beating steadily on the right side. There was no way a heart could migrate from one side of the chest to the other overnight. It was anatomically impossible. Linda, double-check the patient identification, I instructed the perfusionist. She confirmed the wristband, the chart, and the consent forms all matched James Kowalski. We were definitely operating on the right patient. I had two choices: proceed with the surgery, despite the impossible anatomical discrepancy, or abort the procedure. Kowalski's mitral valve still needed repair regardless of its position, and his vital signs remained stable. Against every instinct screaming that something was fundamentally wrong, I decided to continue. The next impossibility occurred when I began connecting the heart-lung bypass machine at 8:45 a.m. Standard protocol requires cannulating the ascending aorta and right atrium to redirect blood flow through the bypass circuit. But when I attempted to clamp the aorta, my forceps passed through it as if it were made of smoke. I tried again, thinking my depth of perception was Hand me the debaked forceps, I said, thinking the problem might be with my current instruments. She passed them to me, and I attempted to grasp the aorta again. My forceps closed on empty air. Are you having trouble with visualization, Dr. Castellano? Dr. Mitchell asked. No, I can see everything perfectly, I replied. But I can't seem to get a purchase on the aorta. Dr. Mitchell moved closer to observe. Would you like me to attempt cannulation? I stepped aside, and she tried to grasp the aorta with her forceps. The same thing happened. Her instruments passed through the vessel as if it weren't there. We looked at each other in bewilderment. Dr. Gutierrez, are you seeing this? I asked. The anesthesiologist leaned over to observe. Seeing what exactly? We can't physically grasp the aorta, Dr. Mitchell explained. But I can see it clearly on the monitors, Dr. Gutierrez said, pointing to the surgical camera. It looks completely normal. Linda Wong, our perfusionist with 15 years of experience, had never seen anything like it. Doctor, maybe we should consider converting to an off-pump procedure. But even that presented problems. When I attempted to place stabilizing sutures around the mitral valve area, my needle would penetrate the heart tissue normally. But when I tried to tie the knots, the sutures would slip through the tissue as it passed through water. I could see the heart, I could see my instruments, but I couldn't make physical contact in a way that would allow me to perform surgery. The monitors continued to show normal cardiac function. The echocardiogram probe showed clear images of the mitral valve and its regurgitation, but I could not physically manipulate the hard tissue to repair it. At 9:20 a.m., I made the decision that still haunts me. I'm going to attempt direct manual palpation, I announced. This wasn't standard protocol, but nothing about this case was standard. I removed my surgical gloves and placed my bare hands into the chest cavity. I could feel Kowalski's heart beating against my palms. Strong, rhythmic. The texture felt normal. The size felt normal. The temperature felt normal. But when I tried to lift it slightly to access the mitral valve, my hands passed through it. I could feel the heart, but I couldn't grasp it. I could touch it, but I couldn't move it. It was as if Kowalski's heart existed in our physical reality just enough to keep and sustain life, but not enough to be surgically manipulated. This is impossible, I whispered, staring at my hands inside the chest cavity. Dr. Mitchell placed her own hands next to mine. I'm experiencing the same thing, she confirmed. I can feel the heart beating, but I can't get a grip on any of the structures. For the next 30 minutes, our entire surgical team attempted every possible approach to establish contact with Kowalski's cardiac anatomy. Different instruments, different angles, different techniques. Nothing worked. We could observe everything perfectly. The heart was visible, palpable, functioning normally, but we could not perform surgery. The most disturbing moment came at 10:15 a.m. when Dr. Mitchell attempted to use the surgical camera to magnify the mitral valve. As she adjusted the zoom, the image on the monitor began to pixelate and distort. At maximum magnification, instead of seeing cardiac tissue, the screen showed what looked like static interference, as if we were trying to film something that wasn't entirely there. Linda, are you recording this? I asked. Yes, doctor, but the recording equipment is showing some kind of technical malfunction, she replied, pointing to error messages. At 10:30 a.m., I made the unprecedented decision to close the chest without performing the planned surgery. We had spent nearly 2.5 hours attempting to repair a mitral valve that we could see and feel, but could not physically manipulate. Kowalski's vital signs remained stable throughout the entire ordeal, showing no signs of distress despite the prolonged anesthesia and open chest procedure. I sutured the sternum closed using standard technique, though even this presented challenges. My sutures would hold in the bone, to require more attention than usual, as if the chest cavity was somehow more spacious than it appeared. As Dr. Gutierrez began reversing the anesthesia, I stepped out of the operating room to call Dr. Elizabeth Hayes, our chief of cardiology, to discuss the case. I needed a second opinion on what had just occurred, and more importantly, I needed to determine how to proceed with Kowalski's treatment. Beth, I need you to come to OR7 immediately, I said. We have a situation I've never encountered before. Dr. Hayes arrived within minutes, and I explained what had happened during the surgery. Her expression grew increasingly concerned as I described the anatomical inconsistencies and our inability to perform the planned procedure. Vincent, that's not medically possible, she said. Hearts don't move between chest x-rays, and you don't lose the ability to manipulate cardiac tissue. I know it's not possible, I replied. But 5 witnesses, including myself, experienced exactly what I'm describing. We decided to immediately perform another chest x-ray and echocardiogram to compare with the pre-surgical imaging. Kowalski was still under anesthesia, so we could perform the studies without delay. The post-surgical chest x-ray showed his heart in normal anatomical position on the left side of his chest, exactly matching the preoperative films. There was no trace of dextrocardia or any other anatomical abnormality. The echocardiogram still showed moderate mitral regurgitation, unchanged from the previous day's study. According to every diagnostic test we performed, James Kowalski had a perfectly normal heart with a valve problem that should have been easily repairable. Dr. Hayes examined the surgical video recording, which had captured most of the procedure, despite the technical difficulties. The footage showed our surgical team apparently manipulating empty air while describing interactions with cardiac structures that were clearly visible on camera. This looks like a coordinated hallucination, Dr. Hayes said, except hallucinations don't show up on video recordings, and 5 people don't typically share identical false perceptions. Kowalski recovered from anesthesia without complications and was transferred to the cardiac ICU for monitoring. His post-operative vital signs were stable, and he reported feeling well, though he was disappointed to learn that his valve repair had not been completed. Over the next 3 days, we consulted with colleagues from Johns Hopkins, Mayo Clinic, and Cleveland Clinic. I sent copies of all the surgical recordings, diagnostic images, and procedural notes to some of the most respected cardiac surgeons in the country. Their responses were universally the same. What I was describing was medically impossible, and they suggested stress-related factors or equipment malfunction as explanations. But then, on October 19th, something similar happened with another patient. Mrs. Elena Rodriguez, a 67-year-old retired teacher, was scheduled for coronary bypass surgery to address blockages in 3 major vessels. Her preoperative workup was completely normal, and her cardiac catheterization films clearly showed the locations and severity of her coronary disease. During the procedure, when I attempted to harvest saphenous vein on her leg for the bypass grafts, I encountered the same phenomenon. I could see the vein clearly. I could feel it pulsing with blood flow, but my surgical instruments could not grasp it. The vein appeared to exist in some state between physical and incorporeal, present enough to function, but too ephemeral to manipulate. Dr. Mitchell was scrubbed in with me again, and she immediately recognized what was happening. It's the same thing as the Kowalski case, she whispered. This time, I was prepared. I had requested that our biomedical engineering team monitor all surgical equipment and malfunctions, and I had arranged for Dr. Hayes to observe the entire procedure from the gallery. I wanted witnesses and documentation for whatever was occurring. The result was identical to the Kowalski surgery. We could observe Mrs. Rodriguez's cardiovascular anatomy perfectly, but we could not perform surgery on it. After 2 hours of attempting various approaches, I again closed the chest without completing the planned procedure. Dr. Hayes observed everything from the surgical gallery and confirmed that what she witnessed matched my description of visible, but somehow beyond our physical comprehension. Two identical cases in 4 days. Both patients had normal anatomy by all diagnostic criteria. Both required cardiac surgery. Both presented the same possible barrier to surgical intervention. I began researching similar cases in medical literature, searching databases for recorded instances of surgeons unable to physically manipulate anatomically normal structures. I found nothing. No case reports, no research papers, no mention of anything resembling what we had experienced. The third case occurred on October 24th. Mr. Anthony Chen, a 52-year-old accountant, was scheduled for aortic valve replacement due to severe stenosis. His echocardiogram showed a calcified valve that should have been straightforward to replace with a prosthetic. By this point, I had requested that Dr. Robert Thornton from our hospital psychiatry department observe the surgery to assess whether our surgical team might be experiencing some form of shared psychological trauma. Dr. Thornton had no surgical background, but could provide an objective perspective on our reported experience. The surgery followed the exact same pattern: normal preoperative imaging, normal initial surgical approach, and then the complete inability to manipulate cardiac structures that were clearly visible and apparently normal in every way. Dr. Thornton observed the entire procedure and confirmed that our descriptions matched what he witnessed. I can't explain what I saw, he told me afterward, but I can confirm that you and your team are not experiencing any form of psychiatric illness or shared delusion. After the Chen case, I knew I could not continue. 3 consecutive cardiac surgeries where we had been unable to perform the planned procedures despite normal diagnostic findings was unprecedented. More disturbing was the possibility that similar cases might have occurred in the past but been dismissed as surgical complications or equipment failures. I began questioning every unusual case I had encountered in my career. How many times had I attributed unexpected surgical difficulties to poor visualization or equipment problems when something far more inexplicable might have been occurring? How many patients had received suboptimal treatment because their anatomy was unstable after patients themselves added another layer of Kowalski, Rodriguez, and Chen all continued to function normally despite their untreated cardiac condition. Follow-up echocardiograms still showed the same valve problems, but none of them experienced the progression of symptoms that would be expected without surgical correction. It was as if their hearts existed in our reality just enough to sustain life, but not enough to deteriorate physiological processes. They remained stable in conditions that should have been progressively worse. On November 8th, I submitted my resignation to the board of directors at St. Helena Medical Center. After 22 years of cardiac surgery, I could no longer trust my ability to help patients when I couldn't predict whether I would be able to physically interact with their anatomy. The hospital administration was understanding but concerned. They offered me a sabbatical, counseling services, and reduced surgical schedules, but I knew that wouldn't address the fundamental problem. I had lost confidence in the basic assumptions that underlie surgical medicine, and without that confidence, I could not ethically continue operating on patients. Dr. Mitchell and the other members of our surgical team have continued working, but they report ongoing anxiety about future cases. None of them have encountered similar phenomena since the Chen surgery, but the possibility that it could happen again affects their performance and peace of mind. I've spent the past month trying to make sense of what we've experienced. I've consulted with physicists about the possibility of cardiac tissue existing in multiple dimensional states. I've spoken with philosophers about the nature of physical reality and medical perception. I've even reached out to researchers studying quantum effects in biological systems. None of these conversations have provided satisfactory explanations, but they have opened my mind to possibilities I never would have considered before. Perhaps human anatomy is more complex than our textbooks suggest. Perhaps consciousness and physical matter interact in ways we don't understand. Perhaps me most is the possibility that James Kowalski, Elena Rodriguez, and Anthony Chen are not unique cases. How many other patients might have anatomy that exists in states between physical and incorporeal? How many surgical failures might be attributed to technical difficulties when something far stranger is actually occurring? The medical profession is built on the assumption that human anatomy follows predictable physical laws. We trust that what we see on diagnostic imaging corresponds to structures we can surgically manipulate. We believe that flesh and blood and bone exist in the same physical reality. But what if some patients exist in states that are only that challenge this fundamental assumption? What if consciousness or soul or some other non-material aspect of human existence can alter the physical properties of anatomy in ways we don't recognize? I keep thinking about those three patients, living normal lives with cardiac conditions that should be progressing toward serious complications, but somehow remain stable. Their hearts beat in the world, but can't be touched by our instruments. They exist at the intersection of physical and metaphysical in ways that medical science has no framework to understand. I don't know if I'll ever return to surgery. The confidence required